Great evening, Doc. Great evening, classmates. This evening, I am going to present the case of V. V is a Filipina woman in her mid-20s. She works as a freelance writer and editor. She likes cats, watching YouTube videos, going out with friends, and cooking. She feels very at home in the kitchen and loves not only to cook for other people, but also to devour delicious meals. When she has the time, she uses her considerable makeup collection to fix herself up because she likes to look polished and put together. At the time of the interview, V was dressed neatly in black jeans, a button-up blouse, and sandals. Her shoulder-length hair was brushed and styled and indeed well put together. She seemed calm while telling her story, speaking in measured tones and taking the time to consider the questions posed to her before answering. She was very articulate in her responses and was very open when replying to questions and sharing her experiences. V wanted to spread awareness about her condition, hoping that it would be able to help other people. Storytelling is her way of paying it forward. A sadness with no name. V is 27 years old, single, and lives with her parents in a subdivision south of Manila. She comes from a small, well-to-do family of 3. Her mother is 70 years old, her father is 71 years old, and she has one 44-year-old brother who is based in the United States with his wife and his daughter. V's relationship with her father is good and loving. However, V's father would be away for days, weeks, or months at a time for work. Left to her own devices, her mother had moments when she would lose her grip. She would punish young V physically and verbally for perceived shortcomings. She would hit V, pull her hair, and lock her in her bedroom. V's father would only find about his wife's treatment of V after V would confide in him. He, in turn, would berate V's mother. V never felt a particular connection with her brother, who was 17 years older than her and was wild growing up. Her brother migrated to the United States, furthering the physical and emotional distance between them. As a kid, V would experience bouts of sadness that seemed to come unbidden, a sadness she could not name. It began when she was still in kindergarten and persisted until high school, when she attended an all-girls private Catholic school. Her academic performance held together despite her gathering emotional storm. She never failed any of her subjects, but she did not excel in any of them either. Feeling that she had the potential to do better, she pursued a medical degree at a local university. However, as she grew older, so did her contemplations on dying. I thought it was just normal for me to think about ways I wanted to die, she explained. I thought that everyone did that. Her mother impressed upon V's young mind that she would not amount to anything unless V did exactly as she was told. Making mistakes, in her mind's eye, yielded images of getting hit, scissors, and sharp objects. Along the way, V had learned one of sadness' many names, and it was called failure. Failure reminded her of difficulties with her mother and all the years of feeling that she had to prove her self-worth. It was as though the only way to prove V's self-worth was by pleasing her mother. All the instances when she felt she's second best or not as good or as valuable as someone else made her vulnerable. Sometimes, the vulnerability would stay for a few days, sometimes for a few weeks. During those periods, she would remove herself from unpleasant situations by secluding and protecting herself from people. Occasionally, She had strong feelings of anxiety arising from a desire to go home, her comfort zone, and those worries would cause stomach pains. Her obsessive-compulsive tendencies, repeatedly closing and opening bottles, closing and opening doors again and again, constantly checking on her pet cats, and getting up from bed to check on things she'd already done, also manifest when she felt anxious. Every day became a struggle. Soon, she could barely get herself out of bed to study and became desperate to shut herself at home. Other days, she would barely sleep. Eventually, she became increasingly unable to accomplish even the simplest of her routine activities. The stressful nature of her college classes, as well as the insensitivity of her professors and peers toward her and her mental health struggles, exacerbated her feelings of wanting to die or hurt herself. It all became so overwhelming that she found herself crying every day at one point. "Everywhere I look, I saw a way by which I wanted to kill myself," she described. "I entertained various intrusive self-harm and suicidal thoughts, just as drowning myself, jumping out of a moving vehicle, injecting myself with various medications, and others," V said. A friend finally had to tell her that these thoughts were no longer normal. It was like a slap on the face, she revealed, when she desperately looked up her psychiatric nursing books and realized that she may very well be depressed. She had to seek professional help before the condition takes her life. In 2008, V and her family sought medical help regarding her condition, and she was diagnosed with major depressive disorder with generalized anxiety disorder and obsessive-compulsive tendencies. Mental health problems seemed to run in V's family, particularly on the maternal side. An aunt and a cousin from her mother's side were previously diagnosed with major depressive disorder. V's maternal grandfather had a history of suicide attempts. Likewise, V has suspected that her mother may also have some undiagnosed mental health issue. V's family had their own reactions to the diagnosis. Although her father was the one to first suggest that V go to a psychiatrist to have her condition diagnosed, he ultimately believed that the cure for V's depression was the strength of her will. Meanwhile, her mother felt denial and anger at the start, treating the psychiatrist with anger and hostility. The brother insisted that they take her only to psychiatrists who would not prescribe her medication, while her sister-in-law believed that she could solve her problems with diet and exercise. V herself initially believed that catharsis would be enough to address her moods. V visited several psychiatrists from 2009 who helped manage her condition with medication and cognitive behavioral therapy. She did not get along very well with her first psychiatrist. V found her lack of genuineness off-putting. V also felt that her psychiatrist did not have much regard for V's preferences about her own treatment. The lack of rapport between them forced V to seek out another, and she found another psychiatrist whom she enjoyed a better working relationship with. An unlikely therapeutic relationship came in the form of her tomcat, Garnet, who was taken in by the family around the same time V was diagnosed. He was an aggressive, rough, and tumble kind of cat, she mused. Garnet was emphatic to his guardian's direst of moods. When she was feeling down, Garnet would lie quietly beside V, unconditionally loving and comforting V through the first few years of her depression. Now, V believes that her family reacted in the way that they did because they all knew about mental health and the stigma surrounding it. Her relationship with other family members has changed for the better, especially with her mother. They are more knowledgeable about what they can do to help her with her condition. Despite their tenuous relationship in the past, V asserted that she and her mother are closer now that V is older and has learned how to deal with her mother. V still meets with her psychiatrist from time to time for cognitive behavioral therapy, and medications help to tune down the noise in her headspace. Suicidal thoughts come and go, though such thoughts don't bother her often these days. When these thoughts arise, she turns to experiences that she enjoys: reading books, playing games, listening to music, watching movies, talking to people, going to the mall, going shopping, and eating out. She also keeps her lifestyle healthy. She refrains from smoking and drinking alcohol. And while she is fond of coffee, she is careful not to have too much of it, as excessive caffeine can worsen her feelings. It took her a few tries to find a job that she enjoys. Despite graduating with a degree in nursing, she eventually decided against pursuing a career in the medical field. She went on to hold an administrative post at her high school alma mater, but high levels of workplace stress caused her to leave. She took on some work teaching English to foreign students, before settling in to become freelance writer and editor instead. Whenever she feels a depressed episode is coming on, her current job allows her to arrange her schedule in such a way that she doesn't take on new projects until she feels better. V is doing her best to work towards a goal that she wants to see to fruition, to be able to support herself and care for her elderly parents. She fights to keep moving forward and keep a positive outlook on life. Her quest for happiness gives meaning to her life. Despite the depression, her desire to have fun with family and friends and to live a happy life gives her the push she needs to keep going. Prayer strengthens her to keep herself together. Many cats have joined Garnet at V's home over the years, most of them rescued from the streets. These cats remain her steadfast therapists in time of distress, her loved ones who come to check her up and cuddle her. One cat likes to come up to V's room on the second floor and meow loudly outside her window, with the concern of a trusted confidant. It is their empathy and their unconditional love that make me love cats, she explained, plus the desire to pay it forward. They help me, so I want to help them have better lives than they would if they were in the streets. Risk for developing depression is affected by several factors that include genetics and family history, psychological or cognitive factors, and sociocultural factors. The confluence of such factors have been found to greatly affect risk for depression. Figure 1 represents the factors influencing depression of V. For the biological influences, mental health problems run in V's family, particularly on the maternal side. An aunt and cousin from her mother's side were previously diagnosed with major depressive disorder. V's maternal grandfather had a history of suicide attempts. V also suspected that her mother may also have some undiagnosed mental health issue. For the behavioral influences of V's depression, V could barely get herself out of bed to study and became desperate to shut herself at home. V also barely sleeps. V is unable to accomplish even the simplest of her routine activities and found herself crying every day. V would remove herself from unpleasant situations by secluding herself from people. For the emotional and cognitive influences, V has a strong feeling of anxiety. She feels that she had to prove her self-worth, and there are instances when she felt she's second best, or not as good or as valuable as someone else made her vulnerable. V's vulnerability would stay for a few days, sometimes for a few weeks, and suicidal thoughts or actions are present. For the social influences, V's father is loving and caring but would be away for days, weeks, or months at a time for work. V's mother had moments when she would lose her grip and she would hit V, pull her hair, and lock her in her bedroom. V never felt a particular connection with her brother, and the insensitivity of her professor and peers towards her and her mental health struggles. V was diagnosed with major depressive disorder or MDD because she manifests most of the symptoms of major depressive disorder. MDD or major depressive disorder is a serious yet commonly diagnosed unipolar depression. A person who experiences a major depressive episode, which can last for 2 weeks or 5 months, will feel extreme melancholia accompanied by feelings of worthlessness and indecisiveness, altered sleeping patterns, significant changes in appetite and weight, and a notable loss of energy during the episode. Simple tasks become arduous, and activities or objects that were once considered fun, exciting, or pleasurable lose their luster. A person who experiences an episode of major depressive disorder may find physical movement to be a taxing and effortful endeavor, and may feel inadequate or hopeless and thinks repeatedly about his or her failures or mistakes. The video that will be played will introduce you more about the different kinds of depressive disorders.
Depression is a very misunderstood disorder. People will tend to stereotype depression and make it seem as though you are typically sad all the time and hate the world, but that is far from the truth. Depression has subdisorders that will have different symptoms, intensities, and causes. Here are the different types of depression. Disruptive mood dysregulation disorder. If you tend to have continuous outbursts of temper, either physical or verbal, and it happens 3 times a week, that is one of the symptoms for disruptive mood dysregulation disorder. Other symptoms that you could experience are feeling sad or moody besides the anger 3 times a week, or having severe outbursts. It's more likely that you have this disorder if these symptoms have occurred for more than a year, or if the symptoms started before the age of 10. Another subdisorder of depression is major depressive disorder, which can also be known as clinical depression. Those with this disorder may have an episode for longer periods of time, while others may only have had an episode once in their life. People with MDD have the following symptoms for nearly a 2-week span, and it will usually arise every day. Feeling hopeless, sad, or numb. Decreased motivation for things that they used to like. Increased or decreased appetite, which could lead to weight gain or loss respectively. Changes in sleep. Fatigue. Being unable to concentrate. Forgetfulness. Thoughts of death or suicide. Suicide attempts. And self-harm. MDD can be mixed with different disorders like anxiety, melancholic features, catatonia, peripartum onset, psychotic features, and seasonal patterns. Persistent depressive disorder, also known as dysthymia, is an ongoing depressive disorder. The symptoms are not as clear as MDD, however, the symptoms usually happen almost every day for 2 years in adults and at least 1 year for children and adolescents. The symptoms that go along with dysthymia are appetite change, change in sleep cycle, low energy, poor self-esteem, feelings of hopelessness, bad concentration, forgetfulness, and lack of motivation. Dysthymia can be mixed with other disorders just like MDD. It can also range in levels of severity. Premenstrual dysphoric disorder is disabling approximately 3 to 8% of women, and no one can really figure out why. The following symptoms occur during the menstrual cycle, and a usual diagnosis would require at least 5 of the following symptoms to be present. Mood swings, increased sensitivity, feelings of hopelessness or being overwhelmed, anxiety, feeling tired and sluggish, a lack of interest in activities, and insomnia or excessive amounts of sleep. The disorder also has physical symptoms, such as joint pain, bloating, weight gain, tender breasts, and swelling. This disorder will affect school, work, and relationships. Substance medication-induced depressive disorder. This disorder is present during the use of medication or during substance abuse. Symptoms include irritability, depressive episodes, bad temper, a sense of hopelessness, and no interest or pleasure in anything. These symptoms will occur when using the substance or when in withdrawal. Most people use drugs or substances to feel better and will usually not notice the symptoms they have for substance medication-induced depressive disorder. Depressive disorder due to another medical condition is another type of depression. Arthritis, diabetes, HIV, strokes, viral infections, and much more can cause you to have depression. Symptoms can include a persistent depressive mood, lack of interest, irritability, and an elevated or expansive mood.
There are various psychological interventions, but this psychiatrist focuses on cognitive behavioral therapy. This cognitive behavioral therapy usually involves efforts to change behavioral patterns of V. These strategies might include facing one's fears instead of avoiding them, using role-playing to prepare for potentially problematic interactions with others, and learning to calm one's mind and relax one's body. The psychiatrist and V work together in a collaborative fashion to develop an understanding of the problem and to develop a treatment strategy. Cognitive behavioral therapy places an emphasis on helping individuals learn to be their own therapist through exercises in the session as well as homework exercises outside of sessions. V is helped to develop coping skills whereby she can learn to change her own thinking, problematic emotions, and behavior. Cognitive behavioral therapists emphasize also what is going on in the person's current life rather than what has led up to her difficulties. And a certain amount of information about one's history is needed, but the focus is primarily on moving forward in time to develop more effective ways of coping with life. Other psychological interventions that can be used for depression are interpersonal therapy, psychodynamic therapy, and mindfulness-based cognitive therapy. For the interpersonal therapy, the goal of this therapy is to treat acute depression by improving interpersonal functioning with significant others. It is based on the premise that disturbances in interpersonal relationships trigger or follow onsets of mood disorders. Thus, this therapy aims to help patients analyze their interpersonal relationships and help them improve their communication skills to resolve difficulties. For the psychodynamic therapy, the psychodynamic therapist assists the patient in achieving a sense of authenticity and uniqueness. The basic principles of psychodynamic therapy can be described as much of mental life is unconscious. Childhood experiences in concert with genetic factors shape the adult. For the mindfulness-based cognitive therapy, this therapy helps clients to step out of the habitual automatic patterns that arise as they become depressed and to prevent them from feeling out of control. The MBCT or mindfulness-based cognitive therapy integrates meditation, mindful movement, and cognitive interventions. Here are self-care tips in addition to psychological interventions.
Everyone deals with depression in different ways. Some try to handle it by themselves, while others get help. We're not telling you that you can fight depression on your own, but there are definitely certain things you can do for yourself that could help massively. Here are 10 self-care ideas that you might want to try. Journaling. You might be surprised at how big of an impact this can have. Many studies have looked at journaling as a way to fight depression, and the results are very promising. Journaling forces you to reflect, and it helps you get things off your chest, even if you're just admitting things to yourself. Reconnect with a friend. Even if you have no desire to get out and talk to people, you should probably at least make an effort. Researchers have looked at the most effective strategies for dealing with depression, and actively participating in your own social life is a very beneficial tactic. Humans are social animals. so we actually need a community of some kind. Comfort food. Certain foods and diets definitely have a strong effect on depression. You could choose to go super healthy, and that definitely helps with your state of mind, but you might be surprised at the antidepressant qualities of various foods, including chocolate, which has serotonin-boosting qualities. Tea and even coffee are actually great for fighting depression, and this is backed by numerous studies. Humor. We've all heard that laughter is the best medicine. Well, that might not be too far from the truth. Humor is actually a great way to deal with depression. Watch a funny movie, see a stand-up comedian, do whatever makes you laugh. Laughter releases endorphins and decreases stress hormones, among many other benefits. St. John's Wort. We all know that antidepressants are one of the most common ways to deal with depression. These are special medications prescribed by professionals, but some might want something a little more natural. If this is the case, then St. John's Wort is definitely an option. This natural herb has proven effectiveness against mild depression, although it won't do much more for severe cases. Physical activity. Sometimes the simplest solutions are the most effective. Time and time again, studies have shown that regular, rigorous exercise is one of the best ways to fight depression. Exercise releases endorphins, which are natural feel-good chemicals in the body. Seeing the physical changes in our body after a hard workout is a great mood booster as well. There's really no downside to getting a little exercise done, and you're pretty much guaranteed to feel pretty good afterwards. Bibliotherapy. Another proven method of dealing with depression is bibliotherapy. Although the word might sound complicated, it's actually pretty simple. Bibliotherapy is the use of books in therapy. This is probably one of the most popular self-guided forms of therapy out there, and it has a great track record. Usually, there's an initial consultation with a professional therapist, and then the patient uses a book to guide themselves along their therapy journey. The book instructs the patient on how to improve their mood, deal with depression, and conquer anxiety. One thing to keep in mind is that it's only recommended for those with mild depressive symptoms. Yoga. A few different studies have examined how yoga can help with depression, and they've come to the conclusion that it can be very effective. Some would say that yoga is just another form of exercise, but in truth, it's more than that. Many people describe yoga as a kind of meditation in motion. It can be spiritual in nature, and it can also be very introspective. The results speak for themselves. Meditation. Meditation might just be one of the oldest self-care techniques in history. People have been meditating for thousands of years, and the effects of this practice are well documented. The aim of meditation is to attain inner peace, which makes it a perfect strategy for combating depression. One of the most popular methods for dealing with depression these days is mindfulness, which is a type of meditation which focuses on being of ourselves, our thoughts, and the people around us. Numerous studies have examined the effects of this on depression, and it has proven to be quite effective. Quite simply, it gives us greater appreciation of our own lives. Massage therapy. It's always good to treat yourself to a nice massage. But if you're trying to pursue a lifestyle of self-care, then you might want to seriously consider massage therapy. We left this method until last for a reason. Massage therapy is only loosely linked with decreased depressive symptoms. It won't cure depression, but it will decrease stress levels. And hey, getting massaged is never a bad thing. What are some self-care techniques that you do to fight depression? Let us know in the comments below.
These are my references. Thank you for listening. Keep safe always.